Hello, PsychU community, and welcome to today's webinar, Take a Stand on Racial Injustice, Perspectives from Mental Health Experts in Advocacy and Psychiatric Healthcare. My name is Bryan Archuleta, and I am from the Otsuka Field Medical Affairs team. I will serve as a moderator for this discussion. Thank you to our participants for joining us. Today's webinar is sponsored by Otsuka Pharmaceutical Development and Commercialization, Inc. and Limbeck LLC, committed supporters of the mental health treatment community. The information provided is intended for your educational benefit only. No CME or CEU credits are offered. It is not intended as, nor is it a substitute for, medical care or advice or professional diagnosis. Users seeking medical advice should consult with their physician or other healthcare professional. When conducting this discussion, our speakers aim to provide you with information that is accurate, not misleading, scientifically rigorous, and does not promote Otsuka and Limbeck products. You may notice that all attendees have been muted. We are recording today's event, and muting the phone lines assures the highest quality of sound. We will, however, hold a brief question and answer session at the end of the presentation. To participate in this, we encourage you to submit questions via the question box on the GoToWebinar panel at any time during the presentation. Now, I would like to welcome our panel who will be leading our discussion. Joining us today is Paul Gianfriddo, Dr. William Lawson, and Daniel Gillison. Paul is the President and CEO of Mental Health America, as well as the PsychU Stigma Section Advisor. Dr. Lawson is the founder of the Institute for Reducing Disparities, Medical Director at Emerge Baltimore, Adjunct Professor at the University of Maryland School of Medicine, and Professor Emeritus at the Dell Medical School at the University of Texas, Austin, as well as the Howard University College of Medicine in Washington, D.C. Dan is the CEO of the National Alliance on Mental Illness. Gentlemen, thank you for taking the time to be here with us today. As a member of the PsychU team and community, and as a Hispanic American, I am proud to share that PsychU stands against racism, bias, and all injustices, and supports diverse and inclusive community now and forever. The PsychU mission statement is improving mental health together. This is compromised that all people are not valued and respected for who they are. Now let's highlight the talking points we will address during today's program. First, we will discuss the current landscape of racial injustice in America. We will then address relationships between racial injustice, mental health, and minority health disparities. And finally, we will share ways mental health advocacy organizations as well as clinicians are addressing the current crisis, a call to action. So we are all aware that the roots of racial injustice in our nation are centuries old. The devaluation of individuals based on race can result in inequality of all sorts, and the following examples name just a few. Scholastic disparity, reduced wealth accrual, decreased access to professional or financial opportunity, lower access to healthy living and medical care, and of course, dealings with the police. So we have come up with some questions now that we would like to discuss with our panel. And the first question I'm going to direct towards you, Dr. Lawson, and then Paul and Dan, if you would like to comment, that would be wonderful as well. So Dr. Lawson, how have the current events surrounding racial injustice and their portrayal on the social and mainstream media affected your daily life, both personally and professionally?
At first, I did not see the relationship, but then I thought about why I actually went into this area in the first place, and laid back to early in life when I was very young and had a chance to go to what was then the state hospital for African Americans, in which people had a communal shower and so forth. Then later on, when I was in medical school, was told, gee, I'm lucky. I'm from a group that don't get depressed. And then still later, started doing some research, finding out disparities, both in terms of access to care, in terms of dosing of medication, people having side effects from medication, as well as problems in terms of getting health insurance and other benefits. Today, when I see my patients and talk to them, I have to struggle with making sure that they can get insurance, that they can get the treatments that they need, and also if I need to refer, recognize that I'm one of the few referrers in my area. Even though there are plenty of providers in this area, nevertheless, there's still a very, very underrepresentation of African American referrals. And I still have my colleagues telling me that I have not worked very much with these patients. Do we have to have some special training to work with them?
Personally, this has been a really difficult time for me. I have 4 children of mixed race. And, when my daughter was in high school, her suburban high school decided to hold a ghetto day as a fundraiser. And they asked my daughter how they should dress. My other daughter was in kindergarten and asked to draw a picture of her house. And when she did, and we lived in a pretty nice house in those days, her teacher just stared at her like, are you sure you live in a house like this? When my younger son wanted to take Latin when he was in middle school, junior high school, they looked at him saying, well, why would somebody like you want to take Latin? And my older son, Tim, who has lived with schizophrenia for the last 30 years of his life and is in his mid 30s, he's suffered from a lot of the kinds of things that we've seen on TV over the course of the last month. The George Floyd killing happened on my birthday, and all I could see when I saw those films was what I saw in my son 15 years ago after he was released from the hospital after he had been assaulted by the police in Austin, Texas. And so at a personal level, it's brought up so many, memories and so many experiences that my children have faced and, my family has faced and so many other families and their children have faced over the course of generations now in all of our memories. And so it has been difficult. It honestly has just been difficult for me to confront this again and so intensely and so personally again, something that we've been confronting me for just the last 3 decades of my life, but for many people, many more. And organizationally, we've seen the effect at Mental Health America. So many more people are experiencing anxiety. So many more people are experiencing depression. The concentration of anxiety, depression, and other conditions is in communities of color. It's in the Black communities, it's in mixed race communities like my children. It's in Asian Pacific Islander identifying communities, indigenous communities. And, we have just seen as an organization this incredible increase in demand for services and for us to respond and to respond with more than just words, but to respond with our own actions, to respond, to make our own programs more available, more accessible, our own materials more available, more accessible, our own work more available, more accessible, with a recognition that for so many of us, for too long, we've been able to set aside the concerns of people who look different from the way we have and focus too greatly on the people who have looked like us.
Thank you, Paul and Dr. Lawson. I have a similar story from the personal. You asked both the personal and professional, so I'll start as Paul did with the personal. And it's exhausting because as you tell it, the pain comes back. So Paul, thank you. From one father to another and one husband to another, thank you. When we bought our home, it was the first single family home we had bought. And we were very excited. We took possession of the keys. We came over to the neighborhood to see the home again and to actually go into the house. And it's on a cul-de-sac, and my wife walked down the street just to look at the neighbors' houses and to see if any of the neighbors were out. And a patrol car saw her and decided that they were going to follow her down the street. Got to the end of the cul-de-sac and wanted to know what was she doing in the neighborhood, and was she, looking for someone? And she said, yes, we just bought the house up at the end of the cul-de-sac. And he proceeded to actually follow my 5'2" wife in his patrol car. And I mentioned her height because she can't go but so fast walking. So you can imagine how slow he was driving to follow her back up the street until she actually stopped, walked up the driveway, put the key in the door, and went in the house. Until then, he did not believe that she belonged here and that what he was saying was true. Now, my wife graduated with her master's at 19, Phi Beta Kappa. Her academic proficiency and her ability to buy this home made no difference. So that's one experience. My other experience is with our son. We have many, but I'll share only two in the spirit of time. Our son was an honor roll student at a university in Virginia. He went out with his roommate, who was also a pre-dental student. And they went to eat, and they were coming back from eating, and they passed a row house where there was a party. They kept going, and 15 to 20 minutes later, two gentlemen went to that home trying to go to that party, and they couldn't get in. So one of them took a rock and threw it through the homeowner's windshield. The homeowner calls the police. The police comes, sees two young men walking down the street. And of course, my son was one of those, and his friend stopped both of them, pulled their revolvers on it, put the revolvers in front and said, "If you move, we'll shoot you." Put handcuffs on my son on that main street with his roommate. They had no idea what was going on, none at all, weren't told anything. And then went and got the homeowner to come identify them. The homeowner says, when he gets there, he says, "What are you doing? They look nothing like the people that I described to you in my 911 call." And actually said to them, "What are you doing?" The police gave no apology, no nothing. These are young men whose peers, their college classmates, are walking by them as they're handcuffed on the side of this main street, and then release them. So my son has that experience, and one of his best friends and his college roommate. I have many others, but those are just two personal stories. I have my own as well. So what that lends to this conversation is, it will take all of us to make a difference, and it will take all of us being able to be anti-racist and to be very good listeners. And professionally, that's what we're doing at NAMI. We started 40 years ago with moms sitting around a table advocating for their sons who were diagnosed with schizophrenia, and medical professionals were blaming it on the way they were being raised. And until they got the medical assessments, these parents decided we need to advocate for our children. And advocacy for NAMI is what we've been doing and is in our DNA. And that's what we're doing right now. We're advocating, and we're working very hard inside of our diversity, equity, and inclusion area of responsibility. Really drill down on what we look like internally, what we say internally, and to Paul's point, what we do. And then we're looking to actually partner with organizations and with people like Paul to really do something tangibly different in terms of where we are in our systems.
Excellent. Thank you so much, Dan. Very powerful information there. So we'll move on to our next question for the panel. And I think we can kind of piggyback on the last part of what you were talking there, Dan. And I'll start with you then for this particular question. Are there areas within the country or maybe organizations that you're aware of that currently have models that can successfully maybe help reduce or even put us on the path for elimination of racial injustice?
The models that I would look at are more focused on mental health care from the standpoint of mobile crisis units, divergence centers, and crisis intervention training. So those are three areas that I am very familiar in terms of some municipalities doing a great job with that. Miami, Oregon, Arizona, those are a few that are doing that. And so I would say that the crisis intervention training, which we've been involved with since its creation 30 years ago, is its whole purpose is to de-escalate situations in terms of if someone is responding from law enforcement to a situation where there's a mental health crisis. That training is a very good training. We'd like to see it be more pervasive than what it is. Out of the 18,000 police commands, we'd like to see it actually expand in terms of its utilization.
Well, I think the good news and bad news. The good news is that there are many such programs, very, very effective. Unfortunately, I had an experience in which the police have been trained for crisis intervention training. And then we had an episode in which an officer shot and killed a new teenager. And I think something similar to that happened in the DC area as well, in which the officer said, I was felt in danger to my life, even though the kid was completely nude. It reflects the fact that going beyond the training, there's still some residual feelings of one, racism, that Black people are inherently dangerous, and two, that mentally ill folks are somehow especially dangerous, even if they don't have any weapons of any kind. One system that I was very impressed for a long time was the VA systems. The VA system makes sure that services are available irrespective of cost, and also they were among the first institutions to have full integration. And yet, we did a study and looked at the services that folks got in the VA system and found African American patients less likely to get the full service benefits of service-connected disability, that they were much more likely to have PTSD because they were all much more likely to be on the front line, and less likely to get some of the medications and treatment and other resources. So the VA system has addressed some of the concerns, but not all of them, and there's still that strong residual of disparities in care. And that, again, I think relates not so much as institutional setting, which is a start, but the individual attitudes towards working with people of color.
I'd like to just jump in there too a bit. And, what I know better is the mental health side too. So I also want to bring this back a little bit to the mental health side. And, the slide that's up notes that Black students are 3 times more likely to be suspended or expelled. Kids with serious mental illnesses are also several times more likely to be suspended or expelled from school. And if you happen to be Black and have a mental illness, it's even worse. And the other piece on this slide that also speaks to what both Dan and Dr. Lawson have also talked about, that 7 in 10 Blacks say they're treated less fairly than whites in their dealings with the police. The places to which I would point in terms of places that are doing this better are the ones who are removing the police from the equation entirely. We should never have built a system for treating a chronic health condition on an emergency basis or on a long-term basis that so involved our public safety officers, our courts, our judicial system, and our jails and prisons. This system, more than a century ago, advocates identified as being inadequate and inept and said this needed to be taken out from under the police. 1913, Clifford Beers, our founder, and others, 1913, said this needs to be taken out from under the police and put into the healthcare delivery system. All of what we did under healthcare professionals in dealing with mental health and mental illnesses, and we haven't done that. But there are a few communities now that have actually taken the steps and said, we're not going to use the police to be first responders. They're not trained to do so. It's been helpful that we've done CIT and other kinds of things that help some, but it hasn't addressed this. Let's be honest, we're still failing at responding to mental health emergencies pretty much nationwide. And those communities that are now stepping up and saying, let's have paramedics, let's have the fire rescue folks, the same folks who are responding to other health conditions, respond to these. I think those are the ones that are taking a step forward to deal with the intersection of the problem, the one that I know best, which is around people who are Black or people of mixed race or other colors and have mental health concerns. And I think we need to go in that direction. I think we have to get all of this out of the jails and prisons. We have to get all of this out of the courts. We have to get all of the first response outside of the police departments. And maybe I'm a little more radical or out on a limb here, but I think we need to get all of that out of that system, that public safety system, put it where it belongs. in the public health system, as NAMI has called for, and Dan has spoken out about. Let's put it in the public health system, and let's treat this now as the health matters. We've known them and recognized them and been advocating for them to be for more than a century.
In Texas, some of the rural communities, we said, let's move towards a system in which the police are not the first responders for some folks with behavioral problems, and quickly found that they were the only institution that had the resources to do it. And not only in Texas, but in other places as well. Part of the ongoing problem has been that folks look at and if you want to have people with behavioral problems, where do you put the resources? Put it in the police department. You do not put it in terms of people who can provide social services. The same way with substance abuse, the similar issue when we had a crisis in terms of excessive substance abuse, get the criminals off the street rather than looking at treatment in terms of addressing these issues. And again, the same issue revolves around what do you do when you look at folks with disturbances. With the schizophrenia and affective disorders group, we've looked at why not relabel people with mental illnesses having neurological disorders as a way of getting around this. There's a strong philosophical and institutional bent towards looking at behavioral services as places in which you bring in control and people who are involved in law enforcement rather than involving treatment and providing the resources to get treatment. So I agree. I think that's a great idea. The question is, how do we change the attitudinal set so that we address these issues by providing treatment rather than providing control and punishment?
Thanks, Dr. Lawson, and I think that's a great starting point for our next question. But first of all, I'd like to say I really appreciate all of you bringing up the role of mental health in regards to our particular conversation, and we're certainly going to hit that here in a couple of minutes. But when we're talking about like how you ended there, Dr. Lawson, how do we change? How do we make change? I think current events have forced a lot of people, maybe a lot of people in the audience, myself, to reevaluate, the racial situation that we have here in America, and a lot of us turn to education to do that. We're trying to educate ourselves on what is actually going on, and we might not have been doing that so much so in the past. Paul, I'm going to ask the panel to address this too, but I'll start with you, Paul. The question is how do you feel, what do you feel the role of education alone is in terms of its impact in helping reduce racial injustice?
Well, education is really important. We need to educate ourselves, but if it doesn't change behavior, if it doesn't change anything that we do, then it's not gonna work. And I've been thinking recently about an experience that we had in my hometown of Middletown, Connecticut, 42 years ago, when a nationwide restaurant chain decided that they were going to put a restaurant in our town. And the name of the restaurant chain was in 47 states, was called Sambo's, right? And the owners of the restaurant chain said, look, this is just the first name of one of the owners and contracted with the last name of the other owner, and Sam somebody, and along with, Mr. Bo something, put their names together and said, we're gonna have this restaurant chain. And a number of communities, including mine, in the late 1970s, found this racist and did a lot of work. I was 24 years old at the time. I chaired the Human Relations Commission, first public thing I ever did. And we led the protests against this and said this is racist and shouldn't happen, and educated people about how the Sambo character had been conceptualized, and and people learned about this and seen this book and stuff like this. It was all wrong. And when the last Sambo's restaurant changed its name? A couple weeks ago. The whole chain went bankrupt, and only the original restaurant stayed open. And it stayed open as Sambo's until this month in Santa Barbara, California. Education alone. We've known about this for 42 years, that one little thing. People were educated about this 42 years ago. It wasn't enough. It wasn't enough until people actually did something. And finally, 42 years later, this little stain, and we can say it didn't start that way, with these owners. It wasn't intentional. It was systemic. It wasn't personal on the part of the owners, but something we learned about a half century ago that we're finally, putting to rest. That's the problem I have with, with just education. Yes, we need to understand this. We need to understand our history. We need to understand, what's happened and how we've continued to maintain this systemic racism for centuries here. But the question is, what are we going to do about it? And I'm back to, wanting to hope that this time, it's going to be different. So let's bring on the education. Let's inform everybody. Let's talk about all this stuff and talk about the things we need to do. But then let's do some really simple things that we need to get done and should have gotten done. And again, let's not just beat everybody up over the fact they didn't do these simple things before 2020. Let's talk about what we're going to do in 2020 and in 2021, that's in our control. While we've all got some power and we've all got the authority that we've got to make a difference. So I know the question maybe was intended to help me into a different direction about the importance of informing ourselves and educating ourselves, but I'm tired. Like Dan said, it's like I'm tired at this point. And a half century of educating people, and for me, it's just been a half century. Other people, it's been longer. We haven't gotten far enough, and we're not going to get far enough until we commit to action.
Yeah, and I want to build on that. We need selfless behavior versus selfish behavior. I would ask you all, the powers in the question versus the answer for me. Think about it, and we've had Blacks very involved in the creation of the technology that's allowing us to see these video clips. Let me ask you all this question. Where would we be? And I've visited a lot of jails in my career, from the towers in LA to Cook County to Shelby County. And I would tell you that there's situations where people have probably said, this happened to me. There was no video. So let me ask you the question, where would we be right now in this conversation if we did not have video capture? Would we be like the Sambos the last one that just wrapped up? Would we be in denial from the standpoint of, that didn't really happen, that didn't happen? Think about where we would be in that conversation. And I would add to the education piece, think about Mr. Christian Cooper, the 47-year-old bird watcher in New York, and Amy Cooper, the person that all he asked her to do was to leash her dog, as all the signs said. And she elected to call 911 and call and say that this African-American was attacking me. Now, if you think about it, let's think about what would have happened had he not videotaped that encounter, that he didn't know that was going to happen, but he said, my gut tells me I better videotape this. The police would have responded, and it would have ended up being something very different. So where am I going on this is that education, to Paul's point and Dr. Lawson's point, is a part of it, but there's some human behavior that has to be addressed here. And this gets into why we're here. And I want to thank PsychU for giving us this opportunity. And we can't be a microwave society on this. This has got to be, we got to be in this for the long haul. And this can't be a 20-second soundbite on the evening news. And so we've got to also have that collective power to keep this going, because it's very easy to move off of it. So hopefully we will stay in it, and education will be a part of it.
I concur strongly. Had the experience. So we did a nice study looking at who's violence in our correctional systems, and found that white patients were more likely to be violent than black patients. And then put a blog in one of the national newspapers and got a firestorm of protests. People saying that's impossible. Black people are inherently violent, so forth and so on. I got emails and everything. So I could probably try to educate these folks for eternity, and their attitudes probably would not change. On the other hand, what I have found useful is that we were concerned because we found that many in our community just didn't understand the concept of mental illness or something to be treated. So we met with local pastors and went and set up programs with local churches. Found out that many ministers simply did not see mental disorders as disorders, and educating them that they should be treated just like you treat physical conditions was very effective in terms of reaching out to the community and having community folk consider going into getting mental health treatment first rather than the other options. It's well known that African Americans in many other communities specialized mental health treatment is the last place you should think about going. And then unfortunately that ends up with them returning to the correctional system and others, which have consequences of much more deleterious and less in terms of treatment. So I think part of it is empowering the community, empowering individuals so that they can start looking at their own options to find quality services and to change the direction in which things are going.
So you guys have brought up the topic of mental health throughout the conversation so far. So now let's move on and really kind of focus on how racial injustice can impact health and mental well-being. The message that we have here on this slide is from the American Public Health Association, and they state that racism is a structured system which can sap the strength of the whole society through the waste of human resources. And that's quite a powerful statement, and it certainly would make one consider the effects of racial inequality and their effects on mental health. Paul, I'm going to start with you here, and I want to have you kind of expound upon a statement that was posted through MHA. And the statement said, when we normalize racism and bigotry, we do violence to our mental health. So please expand upon this for our audience.
Sure, and and I wrote that myself, so it's a way I feel strongly. And what it normalizes is bullying, it normalizes aggression, it normalizes trauma, it normalizes violence. And we know that people who experience trauma, who experience violence, who experience bigotry, who experience bullying, we know that people are more likely to experience mental health conditions in the course of their lives too. And we've certainly seen in during the time of COVID-19 that people cite past trauma as one of the things that is really impacting their severe depression, their severe anxiety. So it's a combination of factors. It's not just the pandemic and dealing with the pandemic today. It's the past trauma that comes back and also interacts with societal experiences. It's something we're experiencing today. And some people may get confused about that. If the first thing they've experienced is this pandemic and they think, well, we're going to get over this. I can get right through this, and it's like, why can't you lift yourself up, power your way through all of this stuff? Well, it's because if this is your first trauma, it's a whole lot different than if this is your 10th trauma or your 100th trauma or your 1,000th trauma. And so I think we need to recognize that there is just a close relationship between a lot of environmental hazards to which we subject people. And systemic racism is one of those. Interpersonal racism is a different one. But there's a lot of correlation and connection between these environmental hazards and people's health. There's an impact on people's physical health, and we've seen that in the disparities that are faced in all across physical health conditions, cardiovascular disease, for example. And we see those disparities emerge in the mental health side too. So we're no different. And as Dr. Lawson was picking up on, I think sort of making the point, it really is kind of really important point about this is that, this is not, these mental health conditions, that we see, the conditions that the way people are responding is not based on them being different. It's based on circumstances that people have grown up in, experiences that people have had, things, powerlessness that has been created. And the solution to that is to, as Dan said, listen to people, as Dr. Lawson says, to empower people. And, and we see the same thing, at Mental Health America. One of the fascinating parts of the screening data that we've had from the beginning with more than 5 million screens is the greater willingness of Black people to say they will do something in follow-up. because everybody makes the assumption, oh, people, they don't want to hear about it, they're not going to do anything. And what that says to me is simply that we haven't built systems of support that are relevant. And part of the reason we haven't built systems of support that are relevant is because we have made people other, and we have not gone in to communities, to neighborhoods, to churches, to places where people are, into the cultural settings in which people reside, and said, what do you want from us? What do you need from us? And how do we deliver that to you in a way that's relevant? You help us do that. And everything, that I put in that sentence about racism and bigotry, it was intended to capture, that spirit that, we've gotten this all backwards for so long and gotten this all wrong for so long. And even for those who have done this unintentionally, and have just naively, well, we need to recognize that so that we can change it and start working from the people we see and the self-addressed needs they identify and the solutions they can propose to us to work in partnership to implement.
Excellent. Thanks, Paul. That, I think your statement, it was very powerful, and your elaboration really encompasses of what the true meaning of that was. And I think it's a really good jumping point here for our next question that I'd like, again, the panel to address here. But Dr. Lawson, I'll pose it to you first. So in regards to kind of what we've been hitting at already, how do racial and ethnic health disparities impact mental health? And then to further expand upon that question, what are the mental health ramifications of those who have been subjected to racial injustice?
The evidence is pretty strong that folks that have not only being exposed to racial attitudes and beliefs, but also a structure of racism has a number of implications in terms of access to services, in terms of self-esteem, and in terms of a sense of powerlessness. What we often find is not only that racism exists, but that even though African Americans and other groups express racial bias that's happened to them, it's often discounted. And not only is it discounted by being ignored, it's discounted forcefully. Folks who promote concept that racism is a key issue often find themselves in job situations in which it become untenable, find themselves in terms of trying to get resources in the community and told that we can't use it for that. They're often told that this is not something that's very important in terms of society. There are other issues that you'll be focused on. So what we're seeing is that we're having a new generation, and I'm sad to see. I thought one of my sons told me, he said, Dad, you're talking about this racism, this dinosaur stuff. We've solved that problem. And now something, a crisis like the COVID-19, is essentially replicating what many of us saw in the past. We almost knew that there's going to be disparities in terms of access to services, in terms of treatment, in terms of who's going to be blamed for it. And we're very quickly finding that the usual theories about what's causing problems in our community goes against, fits into minority populations. This time it's Asians, other times it's African Americans, other times it's Latinos. So it's not just that racism is a passive background noise that's influencing us, it's also a very active process that if we don't acknowledge it, for folks who are exposed to it on a continuous basis will develop symptoms of anxiety, symptoms of post-traumatic stress disorder, pretty much like what combat veterans face. Want to do it constantly. We've seen this reflected when you do cross-cultural studies in terms of hypertension rates, and diabetes and other physical disorders are more common in the African American community in the United States, whereas less common in other cultures in which more equitable systems. So it's both a physical as well as a social phenomenon that has persistent, long-term, persisting effects. And one of the effects that we need to be more clear of is what the concept of learned helplessness, that you're constantly battling against a system that continues to emphasize and to discredit positive efforts. So why should you support yourself and your community? One of the phenomena that we're now saying, by the way, is the increasing suicide rate among young men. something that historically has not happened in the U.S. before. But I think a lot of us feel that part of it has to do with we call it explicit racism, as well as the lack of resources to try to address what the problem that the community has and direct focusing on punitive ways rather than treatment.
Yeah, I'm just looking at the slide, and I'll start with the last part, minority health disparities. In many of our communities, we have food deserts, and that leads into hypertension, that leads into diabetes, it leads into all kinds of health ailments in reference to access to healthy food. I speak to it directly because I lost family members to diabetes, and they lived in those environments, and I know where they shopped and what they bought and what they ate. I also can go back to mental health because I've experienced that in my family as well, and I've lost family members to mental illness. So now let's come back upstream to racial injustice. We talk about ACE, adverse childhood experiences. What I would venture to say is there's not many Black children that if you really examine their childhood experience, hasn't experienced some type of racial trauma. And we get them upstream, and we don't have enough mental health resources that are helping them in schools, that are available to them in schools, that they can access in the schools. And then you lead into knowledge and education and what family members can do to help them. But I would say that the experiences lead into this structure of the racism that we're talking about here. And we seem to address the symptom. And this right here is our moment in time to really get to the cause and to start working on that. So it's bigger than a bread basket, and it is going to take quite some time and quite some resources.
Great, Dan. Thank you so much. And I think that's actually a great jumping point to our next question. So I'll pose this to you and then get responses from Dr. Lawson and Paul as well. So are there standards of care that historically were perceived as racially biased? If so, can you please provide some examples and strategies that we can use to address that?
I would offer to you that in the field of medicine, from what I can speak to, and Dr. Lawson can speak to this better, if you look at the field of psychiatry from the standpoint of Blacks and psychiatry, first of all, the population of available psychiatrists, Black psychiatrists, is 3%. I think it's 16% for psychologists. So in terms of available resources that look like the patient. Now let's go back to a Black male that is going to see a psychiatrist. Their assessment may be very much different than their white counterpart. And they may get an assessment of a level of mental illness from the assessment versus their counterpart, and it will lead them into the justice system instead of the mental health system. So I'll leave it there because I'm not a medical doctor, but there's really great detail out there that indicates that has happened and does happen very often.
I think, Dan, you hit it right on the head, and you're absolutely right. In the field, I can see this all the time. The manpower issue is a big issue. We had almost the same number of male physicians as we did in the 1960s, and despite massive programs to increase the number of people to go into these fields. If you look at access to insurance, the Affordable Care Act was a big help because it hit two things. One, the cost of insurance for everyone, but also the disparity between payment for physical illnesses versus mental health illnesses. And yet there's tremendous pressure within Congress against the Affordable Care Act, and no one else is proposing any of alternatives to that issue. And then we've been looking at a long time in terms of the issue of diagnosis, going back to years, noting that African Americans initially were thought not to have a mental life, underdiagnosed as having depression, always thinking that they are criminals or had severe schizophrenia. In recent years, we're recognizing even more that having a diagnosis of schizophrenia when folks have problems such as post-traumatic stress disorder, bipolar disorder, leads to inferior treatment and poor outcomes. As noted before, if you look at the correctional system, which is heavily African American minority, many of these folks are mentally ill, and folks who are mentally ill in the correctional system are much less likely to get treated for their disorders or to have access to services once they're discharged from the correctional system. So it's not rehabilitation for folks who have mental disorders. So those are the kinds of system things that I think we're aware of and can be done, but it's going to change some resources, change some perspective, it's change some shifting in resources, and hopefully the public recognizes and begin to recognize that the cost of providing incarceration far exceeds the cost of getting treatments for people who have mental problems and substance abuse problems.
So now we've come to our final talking point of this presentation, and that is, what can we do to take a stand in the current climate surrounding racial injustice? So on the slide here, we've shared for our audience examples of statements which have been released with organizations such as NAMI, MHA, as well as the American Psychiatric Association about taking a stand to combat racial inequality. Dan, I'm going to start with you first here. And per NAMI's statement, racism is a public health crisis. So can you share with our PsychU audience that's attending today what your organization is doing to combat racial injustice, as well as what our PsychU members, who are mainly mental healthcare providers, can do to take a stand against racism and to help build a more just and equitable society?
We're doing a number of things. Some of those are in our own house, and then some are externally facing. So in our own house, we're doing town hall sessions with our members. The other thing we're doing is ask the expert sessions with mental health experts that are able to focus on racism and racial trauma. And we most recently had a Ask the Expert with over 5,000 registrants, and it was a African American psychiatrist, Dr. Lawson, that actually did an incredible job of talking about the impact of racial situations to African Americans, and actually walked the audience through what that looks like, what can be done about it, and how to view it. So it was a great session, and we've done many of those, and we have a whole series that we're planning there. The other thing that we're doing is, we're all type A's. We want to see a problem and bring a solution. We're also looking at something that it's going to take a while for it to get here, but we really are advocating for 988, for a 988 number to replace the 9-digit suicide hotline number. The purpose of that is, if you think about a 311 number in your community, just like 911, what we want with the 988 number is that when you dial that 98, well, let's think about it. 911, you have someone in your family having a heart attack. They send emergency management, and they treat it as what it is. Right now, 911, police may come, and it might be a mental health crisis. We'd like to have the 988 number, so that this number indicates it's a mental health crisis, and then a triage team of a social worker, a behavioral health expert, and if needed, an officer will come, and it'll be a mobile crisis response versus a police response. So that's a few of the things that we're doing.
Thanks, Dan. That's very, very impactful. Thanks for sharing that with us. Paul, we have the statement from MHA up here, stating at the end of it there, when human rights are violated, we shouldn't just talk about it, we should take action. So I'd like to ask you the same question as I did Dan. What is MHA doing as an organization to combat racial injustice, and what can our PsychU listeners here today do to take a stand?
Let me start by just referencing a little bit of the last question we were having too, about standards of care, because I think it starts there. And I'm not a doctor, right? I'm not a clinician. I'm not a doctor. I'm a layperson. So I've thought about these things in lay terms. And this is what ties this together, this sense that the trigger to treatment standard that we've had has been danger to self or others for at least the last century. And that coupled with societal racism is a ticket to inequality and inequity. And it's a lot of the reason why we have deprived so many people of their rights and put them into jails and put them into prisons when all that's distinguished them is having a health condition of their brain versus a health condition of their heart or their kidney or any other bodily organ. So I think the first thing that we need to do and that we keep talking about is removing the danger to self or others standard. And that's a total rethinking of the way we have built our mental health system. But moving it more to clinical standards, such as Dr. Lawson has been talked about, and truly applying those clinical standards fairly and equitably, and learning about them so that we don't over-identify or simultaneously under-identify. You know, in the schools, we tend to under-identify our kids who have serious mental health conditions and wait for a behavioral outbreak to happen, and then we suspend or we send them. And so Mental Health America, we're spending a lot of time on that issue too, on the early identification, because with half of mental illnesses emerging by 14, you know, 3/4 by 24, school is the place to catch them. And we are doing the worst job in 40 years right now of identifying kids for special ed purposes with mental health conditions and moving them forward into earlier sources of services and supports. I agree with Dan. We have worked together on the 988 issue. It's a good way at the other end, you know, the deeper end, I'd say, you know, stage 3, closer to stage 4 of dealing with crises by, as I said before, taking the police out of this equation as soon as we can, and you know, and moving into sort of more appropriate responses to emergency situations that they have. So, you know, we've got our upstream needs, we've got our need to restore people's rights and not deprive them by using our judicial system to do that. And we've got our downstream needs to be able to address and identify crisis situations to a much better extent and move forward on that. So we're advocating on that side as well. As we say, in my view, it's just not enough to talk about all of this stuff. And you know, we've got to be action oriented, and we won't necessarily get everything right, but we need to try to move forward here. And we have not been making the kind of progress. And I'm just pointing to the last century because that's how long my organization's been around. You know, Dan's got 40 years, and they've added so much in the last 40 years to this, but we could at least go back and take some responsibility for the last century of advocacy having fallen short, and to say that, you know, the next century of advocacy, the next year of advocacy has to go a lot quicker, a lot faster, and a lot better. And I think that that'll make the difference.
Excellent. Thank you so much, Paul. I'm going to move to our next question now. And we've talked about this and we've hinted at this throughout the conversation today, but I'd like to give you a chance to expand upon it a little bit more. So, but Dr. Lawson, will you please comment on whether the impact of racism is merely due to people's attitudes, or does it have more to do with the structural elements of our society? And when we speak in this regard, how can we then change?
Many people recognize that it isn't until 1960 that the American Medical Association allowed African American physicians to be full members. That had all kinds of implications, in addition to the need to create almost a separate system to provide services. And in fact, as a result of that, the response has been to create such organizations as the National Medical Association, which has taken a different tack from what the AMA is taking, including such things as promoting such institutions as Medicare and Medicaid, which the AMA was initially not supportive of at all. Recently, they had elected their first, in their 100-year history, their first African American president, which is, again, a significant, who has to be a psychiatrist, and to be a significant achievement. Similarly, the American Psychiatric Association elected their first African American president. These organizations had strong programs in place and plans, but not much was done with these, despite protests, active activities by their members because of, I think, institutional racism and the benefits, I think, in terms of promoting and continuing a racist system. So at least now we have organizations like the National Medical Association, Black Psychiatrists of America, Association of Black Psychologists, who can serve as counterbalancers to the professional organizations who are simply moving on small, minimal steps. But at the same time, they do not have the political or the resources that would make substantial difference. The hope is that in the long game, because it is the long game, they will make a difference. But the reality is that many programs that have been implemented, there have been multiple ones by the AMA, APA, and others over the years, have made minimal changes compared to the last 100 years, suggesting the monumental task that we have in terms of changing people's attitudes about this issue and giving it some legitimacy. We did a study looking at how often do you see the term racism show up in the medical literature. And up to 4 or 5 years ago, it simply wasn't in the journals. It wasn't discussed. It was not acknowledged. Minimal changes were made, but minimal resources, including our knowledge, focus on this issue. The hope is that these are a sign that there are some changes, at least at the grassroots level, and hopefully will bubble up and impact our professional organizations as well, because the issues that we're talking about are pervasive throughout our society. They're not just in terms of individual contact with, say, the police department, but in terms of police department, the legal system, as you mentioned, the school system, the educational system, in terms of impacting on why our society is moving in the direction that it is. My hope is that the recent events is showing that the previous model that we have is ultimately self-destructive, and that if we're going to move on as a society, as a country, that we're going to be implementing some of the changes that Paul and Daniel have talked about.
Question in regards to people's attitudes, or is it structural systems? And the systems run with people. So I don't think you can separate one from the other. People run, people develop, people create, people manage, people, and I won't say lead, they manage the systems. So I think that it's individual and it's structural from the standpoint of what it looks like. But at the end of the day, when we hold this thing out and we think about systems, systems are run by people. So I think they are connected. I'll come back to education real quick, and I will just say this, that we need to do an environmental scan. And I think in a number of organizations, they're doing that in school systems. And where am I going with that is going to teachers teach what is provided to them to teach. And you would be amazed at what's not in the history books. There is the word that Dr. Lawson used, acknowledge. There's not a lot of acknowledgement about what Black Americans have provided and that legacy over the last 400 plus years. And that leads to a school system asking a child about what to wear for a ghetto fundraiser. There are accomplishments that need to be captured inside of that history that are currently not even. So if you're looking at the supply chain and the entry point up to mental illness and mental health, it starts back there in terms of that acknowledgement and that history and that education all the way up through. So that's what I would offer. And we focus on SMI, serious mental illness. However, this is a moment in time where we're going to run on parallel tracks, and DEI is a part of our strategic plan. Diversity, equity, and inclusion. And we're doing quite a bit of work in our body of work over the next 5 years in that. And I would just say that as we're running on this track of staying consistent with our legacy of serious mental illness and being the grassroots organization that focused that, we see this as a time where we need to run on parallel tracks. And my closing comments will be a quote from James Baldwin. And he said that not everything that is faced can be changed, but nothing can be changed until it's faced. So I think all of us are facing this head on, and we got to stay the course.
It's not the system distinct from the individuals or the individuals distinct from the system. It's both. And so I think we all understand that we all have work to do as individuals. We all have work to do to rebuild systems. And I do think that systems are essentially going to have to be rebuilt here. I just don't think that the current systems have worked in this particular respect. And starting from the people's youngest years, the educational systems, the health systems, the healthcare delivery system that Dr. Lawson has talked about, that in our lifetimes has been so discriminatory, so separate, so unequal. I mean, we talked about working past this, in most recently about 50, 60 years ago during this civil rights movement, but gets back to a point that Dan was making, that history, we all remember being in school and doing our history classes and never having time for the last 50 years. So we're not educating people about contemporary history very well, and if we were, I think it would be making a huge difference, because what I see is younger people being far more willing to be open to change and to doing things differently. And I also think, hopefully, that we're at a time when older people are a little more willing to follow and to be led than they might have been back in the 1960s, particularly people across all colors, all races. And so, maybe there's a little bit in this for us to see the kind of systems change that we're going to need to see. And frankly, to see NAMI coming so close to Mental Health America's message in looking forward is, to me, a really positive sign that we're all coming together again, when 40 years ago we were all breaking apart.
Thank you, Paul. That's an excellent way to surmise the collaboration and the cooperation between you as an inspiration as we talk about this. So we have one more question that I want to ask Dr. Lawson. How can we as healthcare professionals help combat racial injustice in the United States?
That is a great question. I think part of it is the issue of inclusion and participation. And one of the things I've been more impressed with Mental Health America and with NAMI is that when I first became aware of the organizations, I asked the question, what's the percentage of African American members do you have? And it was almost like less than 1%. But then now, there's a tremendous increase in terms of participation and also in terms of implementing community programs to address our needs. I think this is both in terms of supporting the organizations, but also in terms of making mental health issues a part of the community so that folks feel that they have a role to play. You're not sending your family members and others to some other institution, to jail, to state hospitals, or wherever, that you're actually doing something now to be able to have an impact. And not just NAMI, not just Mental Health America, but also the same thing can be done, I think, with many of our other institutions as well. Inclusion and involvement in terms of the community. Now, I've always been impressed in terms of looking at the Japanese police system. I'm sure it has its faults, but the role of having the policeman as part of the community really makes a huge difference. I've seen programs in terms of other countries such as Senegal and Nigeria, in which the mentally ill are not separated from their families, but are considered with the families, even if they're hospitalized, are brought in to stay within the system and to be involved. So I think those kinds of things can be done, but the barrier that keeps these kind of innovative processes in the U.S. from moving ahead is racism. That new and innovation is not for people of color. It's only for the powerful, the rich, and those who continue to see that they're the ones that are privileged and are entitled. What needs to happen is to recognize for the country as a whole, and professionals should be the ones leading the way in doing this, of saying that what are you providing for the least of you should be maximum treatment, maximum resources to bring about positive outcomes. We didn't even talk about the issue of the housing issue the wealth disparities and so forth. But there are key issues in terms of addressing what we can do to move towards making this a more equitable society.
Bryan, if I could add on to that, you know, we talk about in our classes that we provide across the country, peer-to-peer, family-to-family, that we want to meet people where they are, not where we want them to be, but where they are. In the medical profession, looking at just the numbers in terms of what our medical professionals look like, and we want them to meet the patient where they are. But to be able to do that, they got to be able to know a little bit about the orientation of that patient. So cultural competencies, training and development for our medical professionals is critical. And that needs to be a part of the solution portfolio, because when you're talking about 3% and 16% respectively of psychiatrists and psychologists that look like me, if you will, then that you need to train up the rest of the medical professionals to be able to do this outreach and to meet people, meet the patient where they are. So I would say that that's something that we are very conscious of and are supportive of. And the other thing is retaining our current mental health workforce. We already had, before COVID, if you will, we already talked about as a group the fragmented mental health system, and that fragmentation was not just the supply chain, it was the availability of resources, including people. So that was before COVID. So now you have the situation of COVID, on top of that the economic situation, and then you have the racial trauma and injustice, and you're going to see just an incredible need. We're already seeing it if you look at Paul's reports and studies, research, that it shows that there is this huge need for mental health support. Well, that mental health support has to be provided by personnel, and we got to find how do we retain the existing workforce, and then how do we develop new workforce, and how do we do that? So NAMI is a grassroots organization. It's out there in over 650 communities across the country. So we are out there where the rubber hits the road and wanting to make a difference with this, but we know we need to supplement and augment our mental health care systems, and we got to do it soon.
As we reach the end of the conversation today, I did want to allow you still a chance to leave any brief final comments that you would like to leave and share with our PsychU audience as we end the discussion today. So Paul, why don't we start with you?
Always hope. It's brief, it's to the point, it's on that slide. It's a hashtag I've used with my children and with others as well. Just let's always hope.
We have 5 values: hope, inclusion, empowerment, compassion, and the 5th one, fairness. So those are our 5 values. So we're in this, and fairness and compassion and inclusion and hope.
I'm just impressed that now I'm at a point in my life where I can look at the past and say, gee, we haven't changed that much. But on the other hand, some of the change things that's happening now, I think we got to start of 30, 40, 50 years ago, I am hoping that they're sustaining, not only among the folks out in the street, but also the professional organizations and our providers. And if they are sustaining, I think we really can see some meaningful and effective change.
We've now reached the conclusion of today's program, and I would like to extend my sincere gratitude to Paul, Dan, and Dr. Lawson for their time and effort in the development of today's webinar, as well as to the PsychU community around the nation who's joined us today. We hope that this program was very thought-provoking and provided valuable insight for everyone who attended today. And our point that by taking a stand on racial injustice, we can indeed improve mental health together. Have a wonderful day.